Guys, today's a good topic. It's near and dear to my heart. My goal in life, let's see, what year was that? 1980, Erie, Pennsylvania. Anybody ever heard of Hammett Medical Center? I worked at Hammett Medical Center. I covered the trauma unit. So that meant 11 to 7 if there was trauma, then I scrubbed in on the case with the surgeons because I wanted to be an orthopedic surgeon. So we're going to call it ortho. Okay? And today's topic is how long does a total hip last? Now, why did I pick that? Or knee, doesn't matter. Good, was that knee today? Okay, so we'll do the hip next time. Whoop, correction. Knee. Doesn't matter, guys. I was going to do ortho. I got all these down. Okay, it's funny because I was going to talk about Joanne Betts. For those of you guys that don't know my nurse practitioner, Joanne Betts, let's just say yes, because I have to get the malpractice paid before she'll come back into the building. So she's coming back, which is good. Not yet. But the reason I bring that up is Joanne had 2 hips done, and she dislocated them twice. Okay? So part of what I wanted to talk about is how long do they last? A lot of it's up to the person that has it and how well you take care of it. And it's funny because I was just sitting here thinking about that. You're not allowed to, we're just going to do the hips because of Joanne. You're not allowed to cross your legs. You're not allowed to cross your legs. You can't sit like an Indian. You can't do those things. And her comment to me was, well, that's what I've been doing for 75 years. If you don't change, it's not going to last. Does everybody understand? All right, good. I like the knee better, so I'm glad we picked the wrong topic today. This is an artistic talent that I have. Okay, this is show and tell. Can anybody name this bone? Ooh, I'm impressed. All right, what happens to the patella with the surgery? And then put it back. Or depending on when you have it, they got rid of it completely. Okay, so it depends upon the procedure and when you had it. Okay, so what we want to talk about with the total knee, first off, what do they have to do? Bone here is called the tibia, and the bone here is called the femur. You guys are good. I hear you saying that. Okay? This is why I loved orthopedic surgery. And I'll tell you why I didn't get into it in a minute. Did anybody ever have an erector set when they were growing up or know what they are? I loved erector sets because you can build stuff. Well, that's what orthopedic surgery did for me. When I was in medical school, I loved orthopedic surgery because it was like carpentry. Now, again, I'm old, so it was in the 70s. So when they did a hip replacement, you have to understand, or a knee replacement, you heard a lot of banging because they literally used chisels and hammers. And that's what I liked. I mean, that was fun for me. And so you chiseled and you hammered out the old, and then it was called a reamer. It's a drill, and it reams out the bone so you can put the prosthesis. We'll draw the bone like this, and we'll draw the bone like this. So you put the prosthesis, you literally drill the areas of the bone and place it in. Okay, so back in the 70s, it was a long procedure. They had what was called laminar airflow. to make sure they broke down the barriers of infection as best they could, because if you got infected, you had to get another knee. So the technology in the 70s had not really advanced that far, and most of these were made out of different metals, is what the knees were, most of them were 2 different types of metals. And so we would get the patient in. I'll draw it this way so you can appreciate it better. This is the femur bone, and we'll put T for tibia down here. And so they would drill in, and place the knee. Okay. So again, you have a concept of the procedure. Let's talk about post-op care and pre-op care. I have 2 great cases. 74-year-old, 5'1", 260 pounds. Diabetic, uncontrolled. And she saw an orthopedic surgeon. I won't say where, Allegheny General. Okay? And long story short, she came back to my office with her father, which would have been the patient's mother or husband, and 2 children. And I walked in the room, and they were looking at me, and they said, Dr. X said, Mom will be in a wheelchair in 6 months. Why did you even bring her in here? No one would operate on her. Does everybody follow me? So let's talk about pre-op. Pre-op, you have to get what's called an H&P. You go to your family doctor, so we'll put PCP, and you get blood work, a blood count, chemistries. I always get a urinalysis, and if someone doesn't want you to get one, get it anyhow, because I've had a patient have dehydration during one of these procedures and have a stroke. So it's real simple to pee in a cup, guys. Always get a urine. So this is what we get coupled with a chest x-ray and a cardiogram. Now, why is that? What's important about that? This is surgery. You're being put asleep. Does everybody understand what that means? The tube goes down to your throat. Does everybody understand what that means? Endotracheal. Your trachea is here. Past the trachea, the tube goes down into your airway. And a machine keeps you alive while you're sedated to have this knee done. Why am I telling you like this? It's a surgery. This is serious stuff. So don't take it lightly. And again, what do you want to do preoperatively to make sure the outcome goes well? If you smoke, should you smoke? For how long? Month. I know, quit. You should quit, period. I'm telling you should quit. I'm giving you the talk on quitting some other time. That might be my bookie. Hold on. No. I don't have to take it. I owe money. Teasing. Okay. So, again, for preoperative, what we look at is what is the knee currently doing now, and what procedure time are we looking at that you're going to be anesthetized? 2 hours, okay? They do it real fast now. In 2 hours, you're probably already out of the hospital. But that is the general preoperatively evaluated patient that we see. We want to assume 2 hours of general surgery. What does that mean? That you're general anesthesia, you're asleep, and you have to be woken back up. So, do you smoke? No. You should quit, period. How long? At least a month. 1 month before. Should you drink before? I always laugh because the surgeons I used to hang out with, the orthopedic surgeons, say, no, they can't, but we can. Yeah. But once again, you don't want any alcohol in the system 6 weeks. So 4 weeks tobacco, 6 weeks with alcohol. Why is that, by the way? The tobacco is a constrictor, so less blood flow, makes it harder to heal. And the alcohol goes through the liver. And you don't want the liver being disturbed when you have a procedure done when you're asleep, because all the anesthesia goes through the liver. Ooh, That must be the bookie. Okay, everybody understand? All joking aside. So it's very, we'll come back to this, but it's very important. Why? Because we want to get the best that we can out of these knees. So pre-op, no smoke, 30 days. Alcohol, 6 weeks. What else? Exercise. Probably spelled that wrong. What else? When we say diet, what you want to do is set yourself up for the best possible rehab you can have. What does that mean? You want to have it so that you don't feel bloated. You want to have it so you don't feel like you have to go to the bathroom. You know, what you want to be able to do is prepare yourself. So stop the cigarettes, stop the alcohol, pay attention to what you're eating. How long? Same, month. Like if you're going to have this procedure done, and if you call the doctor to have it done tomorrow, it's probably going to be July. So you have plenty of time. But you really want to get yourself as well as you can be. What does that mean? No desserts. You know, don't do what I do. Do what I'm telling you. So no desserts. You got to skip the desserts. Drink a lot of water. You're not allowed to drink the alcohol. Stay away from sugar. It's important. And watch the carbs unless you're burning them off. Does everybody understand that? Because it sets you up to fail. You don't want any failures with this. Okay, so you're going to make certain that you follow these. Now, are you ready? For pain. I asked that, it seems like a joke, but it isn't. You know how many patients I've had that when I see them after the surgery have the look in their eye like, I'm going to kill you. You didn't tell me it was going to be like this. Because there's pain. Now, two things, good news and bad news. The bad news is there's pain. The good news is it's not the pain you had before the surgery. Does everybody understand that? Well, what does that mean? Well, what it means is you're upset because you're in pain, but I can tell you that's going to go away. Preoperatively, if you don't do something with the knee, that pain's never going away. Okay, so again, you're going to have pain. It's a different type of pain, but it's going to be there. And what's the key to getting rid of the pain? Sure, take the medicines and all that stuff, but follow what they tell you in therapy. You know, and the best thing I would recommend to anybody, get into a facility. You have it here, so you're set. But if anybody else, you want to do 3 hours of therapy a day. You know, make sure you get that 3 hours of therapy a day. And if you guys are signing up for your insurance, make sure you pay attention to those kinds of things. Like, are you in a program that allows you the rehabilitation after these procedures? Because we'll go through the statistics in a minute of how prevalent it is. Like they did over 2 million procedures in America last year. Not all knees. That throws in the hips, and now we're doing shoulders too. So again, back to preoperatively, what do you have to do? These are things that are so important because if you're not prepared, you're going to have a new type of pain and you're not going to want to be up. How fast do you get up after you have your knee taken care of? I heard an hour. You see it? And again, why is that? If you read the articles, some of the articles support early physical activity is very beneficial. But we used to just do where they put your leg in that machine that it automatically bends it. And that seemed to be working statistically. So I personally feel that they're trying to get their length of stay down because they don't want you in the hospital. So the sooner they get you up and moving, the sooner you're moving out the door. You know, but that all being said, you're seeing, and I didn't tell him ahead of time to say that, you're up right away. So two things about that. Number one, the pain as you move gets better. No wonder I steal these pens all the time. I never know what pocket I put them in. There it is. Okay, so the physical therapy happens hours after procedure. I've seen some athletes that the doctor makes them walk back from the operating room pushing the wheelchair. My brother's a sports medicine doc, and these kids that are trying to get professional contracts, they have to play in order to get that film out there. So the technology has advanced, and we'll talk about that, to literally get you up. Like he has people that get hurt on Thursday and play the game on Saturday. Everybody with me? All right, so hours after the procedure, you're going to do the therapy. What is important about the physical therapy with the knee? Extension and flexion. And what do we want? Straight out. Does everybody follow me? Extension. Straight out. That's 0. That's what you want. That's 90 degrees. That's 100 degrees. That's 120. So you want to be able to bring your calf up to the back of the chair. Everybody understand that? Is it achievable? Yes. How? Pain. Anybody that has had it done knows that flexing that knee after it's been placed is painful. But you have to do it. Does everybody understand? And they have those machines that'll help you. So my suggestion is get one of the machines, make sure you're using it regularly, and do the exercises. The one I find that the patients like the most is that you put your leg down while you're seated and then lean forward in the chair. So the foot is down, and as you lean forward, that bends it, and your whole body weight does it. But you have to do it. I have to overemphasize the physical therapy and the pain. What's that adage? You got it. Okay. So preoperatively, we checked medically to get you cleared, so your PCP has to clear you. We know your EKG, your chest x-ray, and your labs are normal, so you're at low risk for an event. What's the most common event post-operatively? Pulmonary embolism. 2, not 1. 2 of the Steeler front 4 died of pulmonary embolism. That to me is pretty phenomenal. You know, if you guys don't know my partner, Dr. Jagiello, when did we start? 91. He trained in Philadelphia as an intensivist. He was the first hospitalist in Pittsburgh. And he put everybody on sub-Q heparin. And everybody thought he was nuts. But that's how he was trained in the late 70s, early 80s in Philadelphia. Now it's standard of care. Because even one pulmonary embolism, especially if it takes a life, is too many. So once again, that's why you're doing all these things preoperatively. Because if you're smoking, increase your risk. If you're drinking alcohol, increase your risk. If you're eating all those fatty foods and all those desserts, increase your risk. So by doing this preoperatively, you lower your risk for the #1 cause of post-op complication, clot, and then of course the clot moves from the leg to the lungs and the heart, and that pulmonary embolism can take you out. As 2 Steelers, I used to know the name, Dwight White, and who was the real tall guy? Greenwood and Dwight White both died of pulmonary embolisms after orthopedic procedures. Okay? So again, guys, we want to again talk about pre-op importance so that post-op goes smooth. #1, pulmonary embolism. #2, what's the most common infection related to a post-op knee? This one got me. I like that, nosocomial. Teeth. Pretty amazing, huh? So you're not supposed to see and get your teeth cleaned 2 months before the procedure and 2 months after. Now, does that mean you can't dental floss and do that? Not at all. We're talking go into the dentist and get the big thing where they beat you up. Okay? So again, 2 on the front end, 2 on the back end, 4 months, because that's the most common cause of infection. What's the second one? Incision. Should you do anything that your doctor... Wait, how would I word this? If the doctor gives you a list of things to do, should you do anything else without talking to the doctor? That's important, guys. You know how many patients I have that the first time I see them, which is usually within a week or so of the surgery, putting vitamin E and some of this other stuff on because they want to hide the scar. You're not going to hide the scar of a total knee. So I'm sorry if you don't want to go out in your bathing suit and show that knee, but you're not going to change it. So please don't put anything on there that your doctor didn't tell you. You know, because again, you don't want infections. I'll talk about that in a minute. You don't want infections. Now, is it super hard to prevent? Not at all. Just common sense, and do what the doctor tells you. That's so important. If there's a special dressing they want, if there's a special way they want you to take care of the wound, if there's something that they've told you to do, please do it. Because these guys have their routines, and they all do well. Okay, so again, infection. Third, dislocation. What does that mean? That means that in the process of doing your walking or your rehabilitation or your posture and positioning, you managed to move and put a torque on that kneecap so that it gets out of position. Okay, does everybody understand that? And you'll know when you do it immediately because you can't bend it. It kind of locks. It gets very, very sore. So call your PCP who will tell you to go to the emergency room. And hopefully they anesthetize you and hopefully they can manipulate it and everything works out fine. What's it come from? Crossing your legs, doing all the stuff you're not supposed to do. So all the list of things that they tell you not to do, please don't do them because you'll end up with a problem. Okay, so the big three, the blood clot, the infection, and dislocation, that probably hits about 65% of the post-op complications that we find that are going to have an impact on the longevity of your knee. Okay, now, the material of the knee we'll say of the joint replacement because it's for shoulders as well. The different types of metals that they've had, from the most recent is titanium. I probably spelled this wrong. Sorry about that. They're stopping using them because they're finding that it can leak into the bloodstream. Okay? So some people have had, not everybody, it's a very small number, but if you're one that has it, it's going to be a problem. So generally what they'll do now is it's called heavy metals. It's a screen, so when they steal some blood, when you go in to follow up on them, if they have any concern whatsoever, all based on your symptoms, guys. So if you go back in, see them usually in a week or two, and then in a month or so, and then if you go back in that 6 month and you're still having problems, that might be part of what they do, because sometimes you can have pains or aches still in that joint related to the actual alloy of the knee. Does everybody understand that? That's important to pay attention, okay? The other one that we find, body reaction to the knee. The fusion, everybody know what an effusion is? I'll show you. What an artist I've become. That's your toes, by the way. Okay, the knee joint. On each side of the kneecap, we use our hands, our fingers to push the side of the tissue. And as we push it, we move our hands and see if there's a bulge. If there's a bulge, that means fluid. And that fluid is what the effusion is called. So we'll put fluid. So if you're doing a lot of work and you notice your knee is swollen, that's not necessarily a bad thing because it's a brand new knee, it's in a new spot, and so swelling is not uncommon. Redness around the incision with swelling is not uncommon. Pain is what gets your attention. And if there's pain, that has to be found out why. So you call the doc. A lot of times they'll have you see the physician assistant. They get an x-ray of where you go, and if there's fluid in there, they have to take it out for two reasons. Number one, it gets rid of the pain. So we'll say rid of the pain. And number two, they look under the microscope to determine what the cause is. And what can they find? They can find inflammatory cells from gout, pseudo-gout, different things along those lines that can come up, and it can come from a stress in your system. So if you've been prone to it, let your doctor know that ahead of time. So gout and pseudo-gout, if you've had those in your past, make sure you emphasize that to your doctor. Okay, so they get the fluid out, they take a look at the fluid, and that fluid determines if there's an infection or if there's some other kind of problem that's leading to that swelling in there. Okay? If all this comes back normal, that there's no infection, then you have to pay attention to your rehab and what you're doing, because that's inflammation in there, and we've talked about inflammation before. That's not a good thing. We don't want the inflammation. So what will they treat you with? They put that Voltaren cream is a common one. Lidoderm with Aspercreme is another one. And again, this is why you have to talk to the doc. They'll have you see the PA. They'll take an x-ray of it. But you want to limit that inflammation, keep it down as best as you can, but still do the rehab. Okay, now, what do we know about the knee? We know that the knee is the joint that enables us to do all the movements that we do, standing up, sitting down, doing all these things. So what do you want to make sure of after you have this procedure done? Do not put more stress on the knee than you need to. What does that mean? Good, these are different heights. Not really. Close. No, they're not. You don't want to be in a low seat. Okay? Does everybody follow me? So should you raise your toilet, put one of those raising toilet seats over the top of the toilet? I would say yes. Should you make sure that you sit in a chair that's higher than most? Yes. Why is that? It's not healed yet. You don't want to put extra strain on it unless you have to. So those are the things that we find that are very beneficial, especially in that 2 to 4 weeks post-op, because that's the time when if something's going to happen, it's going to happen. And again, once you get into that problem, it kind of lingers and stays with you, and you want to avoid that. So please pay attention, not putting extra stress on that knee. So you don't want to do more than what they tell you in therapy, and they will guide you. They'll give you home exercises to do. They'll give you limitations of what you can't do. Please follow what they say. Okay? Now, the next one. Medical issues and concerns. Number one, diabetes. Increased sugar puts you at increased risk for infection. So remember, you started the diet with no sweets, and you were watching what you were eating. Please, 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 please. 60 days, that's what we're asking for. Do the best to keep your diabetes controlled, and watch the sugar. Again, why? Increased risk of infection. So if you're sweet while you're going through this, there's a chance to get infected, and that's what we want to do, is lower the risk of infection. And it's something that it may sound simple, but for anybody that has diabetes and requires different mechanisms to keep it controlled, you know how it can change based on what you eat. So again, please, for the best outcome, you have to make sure you're cognizant preoperatively and postoperatively of the sugar. So the medical issue that's still number one is diabetes. What's number two and number three? Number two still comes down to vascular, and we'll put heart, brain, and we'll put arteries. Again, why is that a problem? Because post-op, for that wound to heal, you need good blood flow. What affects it? Smoking, alcohol. I'll put the sugar down again, the diabetes. And then again, rest is important. And does that mean you have to sleep? No, but get off your feet. If you don't have to be on your feet when you have these procedures done, get off of them. Do the exercises they've told you to do. Do everything they're suggesting to do. But when you don't have to be up, sit down, take a break. Now, once you're through that period, once you get through the initial 2 weeks and then the month afterwards, so say you're into 3 months out, do anything you want to do. And you'll see your restrictions will be let go. Having said that, what are you allowed to do sports-wise? I thought this was interesting. 42 years old. If you're under it versus over it. If you're under it, they allow jogging. If you're over it, walking and hiking. Does everybody understand the concept? Because when you're running, you're banging down on that knee no matter what. Okay, why the 42 cutoff comes, it's all statistics. Okay, but please make sure of this. You're going to feel, once that knee gets better, you're going to feel good. You're going to feel like you can run. You don't want to. Listen to your doctor. If you were a runner beforehand and you're over to 42 and he or she feels you can still do it, that's fine with me, but I'm just giving you the generalities because this is how we keep the knee lasting as long as possible. Does everybody understand this? So we're allowed to hike. You're allowed to dance. Obviously, we'll let you walk. Can you ride a bike? No. Can you ski? No. Now, is this permanent? Not at all. Not at all. How long does it take till you feel like you're back to yourself? If anybody had them done, excuse me, you know. Okay, back to pre-operative, how do you feel? In my patient population, 18 months is what I'd say. What the doctors may give you is a year. What does that mean? I had a 97-year-old that skied after she had her knees done. And to me, I would think that's high risk, like hitting some bumps and stuff, but they claim if you stay on the kiddie trails, you know, and you can get on and off the lift because you've been skiing all your life. She was allowed to ski, and she did fine, and she even said she fell a couple times and didn't hurt herself. But again, guys, that's all back to your surgeon or your PCP who knows how you were beforehand. I don't think I'd recommend anybody skiing at 90 years old. And yet, I haven't had that skiing patient yet. Okay, is everybody with me? This is very important, guys. You have to make sure that you follow the rules of what they're telling you you're allowed to do and not allowed to do. And we go back to the longevity. How many years do we get with the knee? I'll put some numbers, you guys tell me. This is in years. And we'll use over 65. If you do what you're told to do. And that is pay attention. And again, remember, the 90 days, guys, makes all the difference in the world. I've done this for 34 years now, okay? I see the patients. They have to come back to me after they have their surgeries. And the ones that do well and the ones that jump up on the table and they're moving around like nothing's ever happened 3, 4, 5 years later, it's all because they did what they were supposed to do post-operatively. And what am I seeing and what do the statistics say? 15, and then they'll say to 20 years. Okay? Now, what does that mean? If you're 65 years old and you have bad knee, and let's write these on here. It changes your ADLs. These are called activities of daily living. It has you unable to be comfortable in bed, so it affects your sleep. Increased pain up and down steps. Increased instability. This is big. When walking, even with the cane. I'll put cane. We call these indications for, and I say contemplating surgery. I think that you need to look at every alternative that's out there. And I have to admit, I played sports all my life. My knees are a mess. And when I dropped 20 pounds, they didn't even hurt. Unfortunately, I put 15 back on. But I have to tell you, they did not even hurt. I could run up the steps. If you guys know Dana, the girl that works with me now, I beat her up the steps at Ohio Valley Hospital. You know, so I'm telling you, your body can still take care of you, but you have to follow the rules. And once again, back to what's the process of ADLs? Bathing, dressing, cooking, cleaning, shopping. So if with any of these, your knees are causing you such pain that you look at alternative ways or ways to get it done faster, or you're modifying what you're doing, that's what we call you've had a change in your activities of daily living. That's an indication to contemplate the surgery. Okay, you notice I'm not saying to have the surgery, I'm saying to contemplate the surgery. The second one, you're unable to get comfortable in bed. That's a big one. I have a lot of patients tell me that they'll, get into bed not feeling too bad, but say they have to get up to go to the bathroom, or say they just turn, and then all of a sudden they get pain and they can't get rid of that pain, so it makes them uncomfortable and they're not getting their rest. Another one, again, contemplate. Doesn't mean that you have to do the surgery. I'll put a big C for contemplating it. Now, we can't avoid steps. Well, you guys probably can here because there's elevators. But most everything else, there's steps that you have to take somewhere along the line. If you find that going up and down those steps cause you pain, it's not going to get better unless you can do the exercise, change the diet, lose the weight. So that's when you have your decision tree to go through. And the last one that's on there is a big one too. Instability. When you're afraid, everything in your body tightens up. Does everybody follow me? Like if I'm not fearful, I run around. That's how we were always taught playing football. Don't ever tighten up. If you know you're going to get hit, don't tighten up. Stay as loose as you can so that the hit goes through you, as opposed to if you get stiff, you're going to break something. And it's the same thing. If you have a cane and you're still concerned, or you're using a walker and you're still concerned, if you have an instability of that joint that you don't know if it's going to hold you and you're going to fall, that's a big reason to contemplate this surgery. All right, so what we have to understand through the whole process of the longevity is what you do pre-op, and I hope some of the stuff I talked about will stick with you. What we do post-op, posture is big. But I think what it really comes down to is you have to know what you're getting into. And the easiest way to know what you're getting into is to talk to friends or family who have had it done. I've had many, many, many patients tell me, if I'd have known that, I'd have never had it done. Okay? Does that mean the majority of people wouldn't have the surgery and I'm recommending not to? No. Those are kind of the people that can't tolerate pain. And we all know those people. Okay? What about the persons that they'll have it done and they say to me, boy, Doc, I wish I'd have done this 10 years ago. I like to hear that, but I'm glad they waited as long as they did, because remember, they're only giving you 15 years, kind of like 90% of us will do 15 years with that knee without a problem. So if you're having it at 65, at 80, they're talking about doing another one. Good news is, technology that's out there now, they do a lot of minimally invasive procedures, which is why I didn't get into orthopedic surgery, and I'll tell you about that later. But the bottom line comes back to the technology is advancing, but we're talking about today. And if you have that procedure today, how long is it lasting? I can happily tell you about, I think we're up to about 20. I have 20 100-year-olds that have had their knees over 25 years. But interestingly, do you see the combination? If you're 100 years old today, you're taking care of yourself. And if you're taking care of yourself, then you've taken care of that knee since you had it done. And it's amazing. That's what I tell you. It's like I told you, when I dropped 20 pounds, my knees didn't even hurt. We don't understand all the weight of your body is on the knees. And it's so important to understand that. So post-op and the posture is so important to keep yourself, the longevity. And I would say the goal would be 20 years. And I would say all can accomplish it, but you have to think about clots, infections, and posture. What does that mean? If you've had a knee done and you're in perfect health, there's nothing wrong with your heart, you never smoked, you never drank, you're not overweight, and you're a pretty healthy person, should you be concerned about taking a 2.5 or 3 hour trip in the car? Yes. Yes. Like I'm bringing it up, guys, that you have to pay attention now. Once you get these joints replaced, you have to be aware of all the things that can happen. And why am I telling you this? Okay? Let me see if there's another one I wanted to do. No. Let me tell you 2 cases. Case number 1 I was telling you about. My patient with uncontrolled diabetes who came in with their whole family, who said that she was going to be in a wheelchair in like 6 months. Okay? I love telling the story. This patient, not that it matters, but her husband was chief of police where I live. And long story short, what she said to me when I decided to have her get the surgery done was, Dr. Coppola, I can't lose weight. I know if I don't lose weight, my diabetes is only going to get worse. I want to get my knees fixed so I can exercise. I said, okay. She came to me pre-op and said, do I know Dr. So-and-so? And my answer was, no, I don't know that person. Well, my neighbor recommended him, and that's who I'm going to go see. And this doctor told her she'd be in a wheelchair in 6 weeks. Okay? I had her see a friend of mine. Unfortunately, the guy has retired, but there are some people that took his place. And she had both of them done at the same time. Okay? And I find that it was so amazing because I called him, told him how the other doctor thought she'd be in a wheelchair, thought that because of her obesity and her uncontrolled diabetes, she was too high of a risk and he could not get her in good enough shape for her to have the procedure, so he recommended get a wheelchair by the summertime. And this doctor said, you know, Matt, I think she would be okay for getting both of them done. Let's get them both done and put her through some heavy rehab. I'm so happy to say that she did fantastic with them. Her knees don't bother her whatsoever. and she did drop the weight. She ended up having abdominal hernia repaired. And she's happy, and she was just in my office 2 weeks ago, gets up out of that chair, gets on the table. She used to have to hold her cane, and it took her time to get up there. Now she just jumps up. Why am I telling you that story? She did everything she was supposed to do, pre-op and post-op. And I have to tell you, she wanted to prove her family wrong. I have to tell you, she went in with this attitude, like, I'll show you. And that's exactly what it took. But she did everything she was supposed to do, and she got through it and did excellent. All right, my other case. 62-year-old, 5'6", 300 pounds. What did they call it? I forget the name of when you solder stuff on bridges. I forget the technical name, but he ran a crew here in Pittsburgh, okay? This same doctor would not do both of his. And he wouldn't do both of his because he didn't feel that this guy would get through it, is the way I would describe it. So he went to another doctor, okay? And why do I bring that up? I don't know your doctor, guys. And I'm not saying it's bad. If you have family, friends, other doctors or whatever that highly recommend these people and they have great outcomes, do it. But I'm an independent doctor that refers to independent other doctors, and I make sure that no one's telling them what to do and how to do that, and I pay attention to their outcomes. The only reason I bring that up is I have no control over the person you pick, so make sure if you're picking them, you know that they're good. And let me say, I've had many cases where the person has been good, and I've used it based on the patient's referrals after their procedures. That all being said, this particular guy had his right one done and got back onto his gang, as they call it, in 90 days. Now, he was a foreman, but he still did some work, and his outcome was incredible. 0 and 120 with his extension and flexion. It healed up wonderfully, no problems whatsoever. Okay? He had, this was wrong, left first because it was worse. He had the second one done. I think it was like 6 to 9 months, say 9 months later. Post-op went well, but it never did as well as the left one. And again, I don't want to hold you guys up, so I'll make this long story shorter. So what happens is his right knee gets infected. What happens? He had to quit his job. Now, he had enough to retire, and that didn't beat him up. But what I found, I wish I could think of the name of what these guys were. Because it's like the way he described it, it was pretty cutthroat for him to get the job he got. Like it was a real tough position to get. And he finally got there. He had it for 5 years. And now because of this knee getting infected, he was unable to be the supervisor of that crew, and he lost the crew, okay? What happens is he quits his job, and then he gets put on daily antibiotics. And he has to see the orthopedic surgeon every 6 weeks. That was for about a year. And then in the second year that he was going through this, he had to see them probably monthly. And ultimately, he had it explanted. What does that mean? That means that the knee that they put in, they had to take out. And remember what we said, they're drilling a hole and cementing it down, drilling a hole and cementing it up. So back to chisels and drills and all those things to pull it all out. 1 year later, after antibiotics, they put in another knee. So we'll say new knee. Got an infection. Second explantation. So he's now stuck with, do they remove the leg, a below knee or above knee amputation, to make sure that the infection doesn't go through his whole body? Or do they just keep the knee out and make it so that he's not going to be able to bend the knee because there's no kneecap in there, he can't move that bottom? And what he opted for was the permanent explantation, so he doesn't have a kneecap in there anymore. And he's on antibiotics every day. Okay, why do I bring it up, guys? Because this particular person got through the first one so well, he assumed that the second one was going to be a breeze. And he did so well. He stopped drinking. He stopped doing all the stuff. He's a diabetic. All those things he did for that first one. And it kind of went so well for him that with the second one, he wasn't as diligent. And once again, these things happen. And while he had his first explantation, he even had a pulmonary embolism. Fortunately, he lived through it, but now he's anticoagulated the whole time. All right, so we're back to, hopefully I gave you some thoughts of the pre-op. Hopefully we talked about some of the post-op with an understanding of what we need to do. And the two cases I gave you were for two reasons. Number one was your determination. We'll put deter. And number two, you have to be diligent. Because I'm on the other side of this. I would probably say statistically, well over 95% of my patients that have had joints replaced have done fantastic. Now again, we're talking elective. Does everybody follow the difference? If you fall and break your hip, that's a whole different story. Or your knee. I'm talking that we're doing these procedures because you have arthritis, the indications of the constant pain, not feeling stable, having pain going up and down the steps, having pain wake you up when you roll over in bed, those kinds of reasons are why we're doing it, and we want it to last 25 years. I've seen many 25-year knees, many. And that's my point to, you can get 25 years out of these. But all the stuff I just told you, if you don't do this, I've seen them need to be explanted from infections. I've seen where they've ended up, they did great for a while, and then all of a sudden they're sitting around, and what happens is they lose the extension and flexion. So now instead of 0 and 90, which we'll accept, they're at, say, 10%, meaning they can't get the leg straight, and they only get to 70%. Still functional, but it's not what you set out to do. So I emphasize the longevity comes from paying attention to what you're doing well before you have the surgery. And then having that stick-to-itness, because if you don't have it, I don't know if I would recommend it. You know, I would have to be individualized based on the patients. The one that I told you, she wanted to show her husband, the chief of police, and her daughters that she was going to do well. I had a good feeling about her, and she did fantastic. But the guy that was part of this, gang that was doing these bridges in Pittsburgh, fantastic. And I swear if it had done the same thing the second time around, I don't know for sure, you never know, but my sense was he would have had a better outcome. Still could have been working. And that's why I emphasize all the joint replacements. That's why when you guys told me it was knee instead of hip, it's the same talk. The whole thing is pre-op and post-op. You have to be able to prepare yourself as best you can for these joint replacements, and you have to follow post-operatively what the doctor tells you. And then again, please, one of the things that I find, you have to go from participating, I probably spelled that wrong, sorry, to spectating. I'm in that mode now. Kids were all home for the holiday, and I have a basketball court. I did not play basketball. And they were all giving me grief. Come on, Dad, last year you scored all the points. Because I played with my young daughters, and they did all the running. I just stood there and shot. But the point comes back to, if you're thinking of having a procedure done, preparation for that is to stop all what we call high-impact exercise. So something that's banging your leg down. So when they say dancing is okay, I don't know if I agree with what's that stuff called? You guys all kick your feet. I forget what that is, square dancing or whatever. Please pay attention, guys. All joking aside, I want to make sure you understand you don't get these things done thinking that they're all going to be a breeze, and because your next door neighbor or your cousin or your aunt or your brother or sister did great, it's not a guarantee. And please remember the pain as well. It's a different type of pain. The pain you have in your knee before the surgery, it's gone after the surgery. But the pain you have from the procedure they did, which again is putting that new metal piece in one bone down and one bone up and making sure it fits, and then closing everything back up. So once again, it's not a simple procedure, and you're going to have pain related to that. Everybody's different, but you figure it's going to be a good 2 to 4 weeks at least as that heals that you're going to have that pain with you. And then again, you want to make sure posture. I can't overemphasize the posture, guys. Please make sure you're not getting up on a low seat and trying to stand up. That doesn't do you any good. So again, raise the toilet up if you can, sit on chairs, or put cushions on the chair when you sit down so it props you up. Because the least you have to do to that knee post-operatively, the better that it heals. Okay, now, what about other options? Partial knee replacements. Okay. Generally, when you see partial, you may need the whole one down the road. The data is soft. There's not any statistics out there that give you a set amount of time. So if you have the partial knee replacement done, they're not giving us whether it's 5 years, 10 years, 20 years, mainly because the procedure is only about 10 or 12 years old, and not everybody gets them done. You know, what these are ways to try to help out the pain that you're having without having to go through that general anesthesia surgery. Remember, 2 hours, that's what we always figure on. So these partial ones, it's kind of like the arthroscope. You know, they did arthroscopes when you tore a meniscus or you tore a cruciate ligament. They were able to, with the scope, get inside that knee and manipulate it so that you were without pain, and it would stop the process. That's similar to what they're doing with these partials. They go in, they save the patella, they move everything out of the way, and again, they try to just clean up the arthritis, meaning that all the things that they see in there that are destroyed from the arthritis, they clean it up, and then there's different kinds of things they're putting in the knee. You know, a lot of it have to do with like the rooster. Everybody's heard of the rooster tail. They give the shots that will regenerate the cartilage. It all has to do with that whole technology. And it's real. Don't get me wrong. I'm not refuting it. I just feel this gives it away. Now, if you can have the partial done and lose the weight and change your diet and do all the things that it takes to stay well, stay healthy, and take the strain off of that knee, I would definitely look into it before you had the whole one done. But always check with the doctor, because the orthopedic surgeon can tell you about the knee. The knee comes in 3 flavors. Now we'll see the great drawing here. This is the femur bone. This is called the tibial plateau. And the fibula sits right here. And the patella's in here. Okay? So what happens is there's ligaments on the outside like this, and then they crisscross in the middle. These are called collaterals. And these are medial, and then we call it anterior cruciate. And so what happens is the way this is all set in your body, it's perfect until you disrupt it. Once you disrupt it, you're going to get inflammation. So the process in and of itself, you're going to end up with an inflammatory situation. When does the inflammation go away? It goes away as it heals. 3 areas that they look at. That's why they'll call it Compartmental Osteoarthritis. These two outer edges, they call it bone on bone. See the space between femur and tibia? And then in the center where the patella is, as it comes down and narrows, the center will also touch. That's what's called what would it be? It's a compartment. Tricompartmental. There you go. That's the arthritis that's in there. If you are, and we'll draw it this way so you see it again, if you are literally what's called bone on bone, you can try to strengthen the muscles above and below that'll give you some space, but you're not going to change that. Technology's advancing. They're doing different things. These partial replacements, I'm not sure that's the way to go. What they're looking at is the different technology of the polymers that they can put in there to break up the inflammation and still keep things moving. That's probably the technology that's going to next come out. It's like the stem cell. I don't know if anybody's had the stem cell shots. I have a friend, Dr. Scarpone, here in Pittsburgh that does them. He used to work with my brother up in Erie, who's a sports medicine doc. Very, very good. But once again, once you get your relief, you got to get in shape. That's the whole thing that we have to do. So again, guys, they'll look and see tricompartmental disease, meaning that you're bone on bone. They will say that you need to see your PCP to get pre-op clearance. And post-op, you usually see the doc within a week to two, and then usually like 6 to 8 weeks after. And then depending on how well you do, they kick you out for a while. What you have to pay attention to is follow the doctor's direction. And remember what I'm telling you, posture is important. And I always throw in dental, get an antibiotic. Why do I put that in there? Unless you have allergies to antibiotics, they're not going to hurt you. And what is that usually? 3 days. Okay? The day before you go to the dentist, the day after you see the dentist, or the day you see the dentist after you see him, and the next day. 3 days of antibiotics is all you need. So I don't care if your cardiologist and all your other doctors say, no, please, I've seen too many infections. If you're going to the dentist, take the antibiotic if you've had the knees replaced. Those are some pointers and tips for, again, it's post-op. You have to do these things, guys. And if you don't, and you get yourself in a risk, remember what I told you about my patient that ran that gang. You know, when they have to explant them, fortunately, he's only one of 3. And I've had a lot of patients. I've had hundreds of patients have this done. So I've only had 3 people need an explantation. The other 2, they were able to put the knees back in after they took care of the infection. This one patient's the only one that still doesn't have the knee. So the good news is it's very safe, and if you listen to what your doctor tells you, you should do fine. I would say you have a good, say, 12 years to be right in the middle once you get it replaced. If you pay attention, I have many 25 years and beyond. So it definitely works. Figure you can get to that 20 to 25 years as long as you pay attention to what you need to pay attention to. Listen to what the doctor says. Okay? One other thing. Are braces for the knee beneficial? And of course, this would be pre-op. Like, this is stuff you should be doing beforehand. The answer is yes. My knee is good now because my brother did. It's called PRP, platelet-rich plasma. He's the sports medicine doc. But I hurt my knee playing softball. And, yeah, not limping, but it definitely took me out. I quit playing softball, quit doing all the other stuff I used to do. And I got those shots, and I was able to participate again. So there are things that you want to also look at. Talk to your doctor, talk to the orthopedic surgeon, even ask them, doctor, is there anything else you'd recommend before I go through the surgery? And they'll be honest, because most of the orthopedic groups have all those services under one roof. So the doctor that does the stem cell, the doctor that does the PRP, they're part of the group. So it's not as if they're going to say no because they don't want to lose your business. It's still part of their group. So please, before you get the procedure done, ask the doctor if there's anything else that could be done before you have to have the surgery. And then please pay attention preoperatively. Probably evolve them to smoking. So if you're a smoker, please stay away from it because it really leads to outcomes that are poor. High risk for a stroke and a clot, and very high risk for an infection. Okay, guys, sorry it took me so long, even though I came early. Any questions? Yes, sir.
When you get knee replacements and knees rattle, that's serious?
I would say that depending upon the mechanism and what the metal is, so talk to the orthopedic guys. The rattling could come from just it being loose at the kneecap itself. If that's the case, nothing to worry about. But if it's loose, well, I would say it's probably just the kneecap then rattling. I would say it's probably nothing, but check with them to make sure. Good. Any other questions, guys? Good. Thanks for having me. Now I get to drink my coffee.